This course contains narration and videos with audio. Please have your headphones or speak. Please take a moment. The producer and in this course, you will learn about the different components and basic functions of a permanent pacemaker system and discuss the differences between single-chamber and dual-chamber pacemakers. We will learn how to recognize both atrial and ventricular paced rhythms, capture and fusion beats on an electrocardiogram. Finally, we will introduce a basic approach to ECG analysis when troubleshooting pacemakers. This menu provides the topics covered.
This video will serve as an introduction to pacemakers. I'm going to discuss the different components that make up a pacemaker system. We're going to look at anatomical considerations when implanting a pacemaker. We will discuss the difference between single-chamber and dual-chamber pacemakers and review the basic function of a pacemaker system. I'll show you what a pacemaker spike looks like on an electrocardiogram, and we'll learn to recognize both atrial and ventricular paced rhythms. Finally, we'll learn how to recognize pacemaker capture and even fusion beats in this video. Here is a typical example of a permanent pacemaker system. It's not exactly typical because this pacemaker happens to be compatible with an MRI. Patients with most other pacemakers are not allowed in an MRI machine. But the pacemaker consists of the can, which we also refer to as the pulse generator. The pulse generator has a titanium shell that contains the battery and the electronics, and the top part with the pacemaker wires plug in is referred to as the header. The wires, otherwise referred to as pacemaker leads, attach to the inside of the heart muscle either passively with a tip that looks kind of like a grappling hook, or more commonly there's an active fixation mechanism that looks like a little tiny corkscrew. Now, for the most part, pacemakers are used to treat bradycardia, so either sick sinus syndrome or AV block will be an indication to use a permanent pacemaker. So when you implant a pacemaker, you actually insert the leads into a vein. If this is your clavicle and your sternum here in the front, the two veins that drain the arm include the brachial vein and the cephalic vein. The cephalic vein actually joins up with the brachial vein. When the brachial vein passes the axillary line, it becomes the axillary vein, and it runs across the anterior chest wall and then dives under the clavicle into the chest to become the subclavian vein. As it passes under the clavicle, it's the subclavian vein. There's the jugular vein that comes down here, and internally this meets up with the jugular on the other side and the other subclavian vein, and they form the superior vena cava, which then leads to the right atrium, and of course the tricuspid valve and the right ventricle, and then you have the RV outflow tract that leads to the pulmonary artery that goes out to the lungs. Okay, and that's the venous circulation. Okay, so how do we implant a pacemaker? We make an incision here, somewhere on the chest wall, and we find either the cephalic or the axillary vein, and we thread the wires into that vein. Wires can either be inserted into the right atrium or into the right ventricle. But now these wires come out the surface, and we hook them up to our pacemaker generator, and then we shove it all underneath the skin. So the pacemaker sits in a pocket underneath the skin with the excess wire coiled behind it. And it sits there, and it functions to keep the heart from getting too slow. The way it functions is it sends out tiny electrical impulses, very brief impulses, on the order of about 0.5 milliseconds. So 1/2 of 1 millisecond is equal to about 1/2000th of a second. And these little tiny impulses result in depolarization of either the atrium or the ventricle or both. Now, when you look at the electrocardiogram, a pacemaker spike often looks like a little tiny hair followed by its electrical event. Now, if it's an atrial pacemaker, that little hair, which is known as either the atrium or the ventricle or both. Now, when you look at the electrocardiogram, a pacemaker spike often looks like a little tiny hair followed by its electrical event. Now, if it's an atrial pacemaker, that little hair, which is known as the pacemaker spike, will be followed by a P wave. And if it's a ventricular pacemaker that's operating, then you'll see a spike that's followed by a wide, bizarre-looking QRS complex. So you can have atrial spikes and you can have ventricular spikes. Now, how do we know that the spikes are effective? Well, you'll see some kind of electrical event following it. In the case of an atrial pacemaker, you should see a P wave. And in the case of a ventricular pacemaker spike, you'll see a QRS complex. Keep in mind that the QRS originates from the tip of the wire, and so it's not going to follow the normal Purkinje system. Since the wires are inserted in the right ventricle will depolarize first, and the left ventricle will depolarize through slower intramyocardial pathways. And so the QRS complex will kind of resemble a left bundle branch block pattern, as I've drawn here in V1, with a broad QRS duration, predominantly negative in V1, with an upright T wave. And that's what you should be looking for after a pacemaker spike. Now, sometimes the pacemaker spikes are going to be huge, and sometimes you can barely see them. But we'll talk more about that in the next video. At any rate, let me show you what it looks like to have a pacemaker. Here's an example of a patient who has a single-chamber ventricular pacemaker. You can see a normal sinus rhythm with a first-degree AV block and a slightly widened QRS complex. But right here you see a very large pacemaker spike that lands in the middle of the PR interval, and what you notice is that the QRS becomes distorted. This initial Q wave is a little larger than the Q wave here. And so this pacemaker has begun to capture the heart. Capture is the word that we use to refer to the response of the heart muscle to the spike. Now down here you notice the pacemaker spike is occurring even earlier, so the P wave hasn't really had a chance to conduct down the AV node, and what you have here is a fully paced QRS complex. It's wide, it's bizarre, and then you've got these secondary T wave abnormalities. So that's what we have for this bottom strip. Now notice the P waves disappear. So this pacemaker is not really paying attention to the P waves. This is a single chamber ventricular pacemaker, and as you can see, single chamber ventricular pacemakers will sometimes result in ventricular pacing and you lose AV synchrony. So it will actually compete with the patient's underlying normal sinus rhythm. But this is normal pacemaker function for this kind of pacemaker. That's the main reason we try not to use single-chamber ventricular pacemakers in people who have an intrinsic sinus P wave because of this problem that you get with competition between the sinus rhythm and ventricular pacing where you lose AV synchrony. Just so that you know that this is a fusion beat because the QRS complex is part waves. This is a single-chamber ventricular pacemaker, and as you can see, is the word that we use to refer to the response of the heart muscle to the spike. Now down here you notice the pacemaker spike is occurring even earlier, so the P wave hasn't really had a chance to conduct down the AV node, and what you have here is a fully paced QRS complex. It's wide, it's bizarre, and then you've got these secondary T wave abnormalities. So that's what we have for this bottom strip. Now notice the P waves disappear. So this pacemaker is not really paying attention to the P waves. This is a single-chamber ventricular pacemaker, and as you can see, single-chamber ventricular pacemakers will sometimes result in ventricular pacing and you lose AV synchrony. So it will actually compete with the patient's underlying normal sinus rhythm. But this is normal pacemaker function for this kind of pacemaker. That's the main reason the pacing and you lose AV synchrony. Result in ventricular pacing and you lose AV synchrony. So it will actually compete with the patient's underlying normal sinus rhythm. But this is normal pacemaker function for this kind of pacemaker. That's the main reason we try not to use single-chamber ventricular pacemakers in people who have an intrinsic sinus P wave because of this problem that you get with competition between the sinus rhythm and ventricular pacing where you lose AV synchrony. Just so that you know that this is a fusion beat because the QRS complex is partly due to normal conduction down the His-Purkinje system, but partly due to the pacemaker spike capturing part of the ventricle. And then this beat is fully paced because it looks exactly the same as all of these beats where there's no P wave to be seen. So these are fully paced, these are conducted, and this would be a fusion beat. The most common indication for single-chamber ventricular pacemakers is when someone is in permanent atrial fibrillation. So here's an example of a patient who is in atrial fibrillation. You can see fibrillatory activity here in the baseline, but you also see these pacemaker spikes very prominent here in front of every QRS complex. The QRS complex is distinctly widened with secondary T-wave abnormalities, so this is pretty typical of a paced rhythm. We just simply call call this electronic ventricular pacemaker or ventricular paced rhythm, but when you're reading an electrocardiogram like this, you have to try to figure out what the atrium is doing. Don't just leave it as ventricular pacing. Mention that there's underlying atrial fibrillation, but all you can say is that the AV node is conducting more slowly than the pacemaker because the pacemaker is really driving the rhythm. Now you can measure the pacemaker rate, and you should find it to be very constant. And here we have 300, 150, 100, 75, a little less than that, probably 70 beats per minute. Generally, pacemakers are programmed on the 5s, 55, 60, 70, 75, 80, thereabouts. So, but at least from one beat to the next, the ventricular pacemaker should be very regular. I mentioned that there are pacemakers that have atrial leads, and here's an example of an atrial pacemaker. This time you can see a spike that's very prominent. It looks like a very, very narrow signal in front of every heartbeat, but you can see that the pacemaker spike is followed by a P wave. And then there's a bit of a first-degree AV block, but the QRS complex does not have pacemaker spikes in front of it. The QRS complex is coming from the Purkinje system, and there does happen to be a right bundle branch block pattern here, and this patient also has a right axis deviation. But the point is the pacemaker is functioning in the atrium, and it's making up for someone who perhaps had sinus node dysfunction and had sinus bradycardia. Atrial pacemakers can restore normal atrial rhythm, and they don't necessarily need to pace the ventricle if AV conduction is intact. So this would be read as an atrial paced rhythm with a first-degree AV block. And the last example here has both atrial and ventricular pacing spikes. So this is an AV paced rhythm, or atrioventricular paced, or AV sequential pacing. There are a number of different names for it, but notice that the atrial spike is followed by a P wave, and the ventricular spike is followed by a QRS complex that looks pretty typical, wide, left bundle branch block looking, and secondary T-wave abnormalities. So now when you see this on an electrocardiogram, you can label this as a dual chamber paced rhythm. In summary, permanent pacemakers are electrical devices used to treat excessively slow heart rhythms. They consist of the pulse generator and the leads. The leads are inserted through a vein and are attached to the inside of the atrium and the ventricle and connected to the pulse generator, which is implanted in the tissues below the skin. Pacemaker activity on the ECG is recognized by the presence of pacemaker spikes. Atrial spikes are followed by P waves, and ventricular spikes result in a wide-paced QRS complex. In single-chamber ventricular pacemakers, we can often see fusion beats, which occur when the QRS complex is partly from capture of the ventricular myocardium by the pacemaker spike and partly from the P wave conducting down the normal conduction system. I showed you examples of ventricular pacemakers, which are most often used in patients who do not have an intact P wave, such as patients with permanent atrial fibrillation. We also saw examples of atrial pacemaker spikes. In this case, an atrial spike is followed by a P wave, which is then conducted down the AV node to the ventricles normally. Atrial pacing is most often helpful in patients with sinus node dysfunction. And finally, I showed you how to recognize atrioventricular pacing, otherwise known as AV sequential pacing, with an atrial spike followed by a P wave and a ventricular spike followed by a QRS complex. In this video, we're going to talk about single-chamber pacemaker systems. I'll discuss the indications for pacemakers, I'll teach you the nomenclature that we use to describe different and of a single used to treat symptomatic bradyarrhythmias. In the top strip, there appears to be a serious problem with sinus node function. There's a long sinus pause here, and there's obviously a problem with underlying sinus bradycardia. In sinus node dysfunction, symptomatic bradycardia is an indication for a permanent pacemaker. In the second strip, we see an example of complete AV block with a slow ventricular escape here and a long period of asystole. Even in the absence of symptoms, complete heart block is an indication for a permanent pacemaker. One variety of AV block is seen in patients with atrial fibrillation who present with a very slow ventricular response. Since the AV node determines the ventricular rate during atrial fibrillation, a very slow ventricular response indicates significant AV node dysfunction. For the most part, heart rate and the presence of pauses determine whether patients have symptoms. And in sinus node dysfunction, symptoms are very important in determining whether a pacemaker is indicated. However, patients with severe AV nodal disease often need to have a pacemaker implanted to prevent serious symptoms. Atrial fibrillation with a slow ventricular response is a classic indication for a single-chamber ventricular pacemaker. We'll talk about how to prevent serious symptoms. Atrial fibrillation with a slow ventricular response is a classic indication for a single-chamber ventricular pacemaker. We'll talk about how these pacemaker systems work later on in this video. But for now, let's review how pacemaker systems are constructed. In this illustration of the heart, we can see the 4 chambers as well as the electrical system. A permanent pacemaker includes 2 components: the pacemaker itself, also known as the pulse generator, affectionately referred to as the can, and the pacemaker lead. The lead is inserted into a vein, which then runs to the right atrium and here to the right ventricular apex. The ventricular lead can be placed anywhere in the right ventricle, since most leads have a kind of a corkscrew mechanism at the tip that actively attaches the lead to the inside of the heart. The electrical conductor within the lead is not just a straight piece of metal, because as the heart moves, the lead is called upon to flex and bend, and a straight conductor will often suffer from mechanical fatigue and be prone to breaking. Just like this telephone cord, pacemaker lead conductors are arranged in a helical fashion, and they're able to bend very easily and with very little stress. The body of the lead is covered with a special kind of insulation. The tip of the lead is in contact with the heart muscle, and the electrical energy flows out the tip of the lead. It has to flow through the tissues back to the can in order to complete the circuit. The tip of the lead is the negative pole, and the can is the positive pole in the circuit. This kind of pacemaker system is referred to as unipolar, referring to the single pole at the tip of the pacing lead. The other kind of system is known as a bipolar system. The lead is a bit more complex in its construction. There's a helical conductor that runs down the length of the lead, but then around that is a second electrode that looks like a ring, and this is connected to a second conductor that's wound as a helix around the inner insulation, and then there's yet another layer of insulation that runs on the outside. In a bipolar pacing system, the tip remains the negative electrode, but the positive electrode is this ring near the end of the lead. The electrical energy then flows between these 2 electrodes, and the can is not part of the circuit. In this illustration, the right ventricular lead is a bipolar lead. It has a distal tip, which is the cathode or negative electrode, and then has a proximal ring electrode, which serves as the anode or positive electrode. Pacemaker systems can have a single lead like this one, or you can have a dual chamber pacemaker system like this, where a second lead is inserted and attached to the right atrium. Here's a rhythm strip from a patient with a single chamber pacemaker. We can see there are little tiny pacemaker spikes in front of these wide, bizarre-looking QRS complexes, but then the patient's own rhythm comes through with a narrow QRS complex preceded by a P wave, and it seems that the patient does have a slight first-degree AV block. In this case, after 4 normal beats, we see a fusion beat, which means there's a pacemaker spike in front of the beat, but there's also a P wave, and that the QRS complex looks intermediate between a fully paced QRS and a conducted beat. Part of the ventricle was depolarized by the normal Purkinje system, and part of the QRS came from the pacemaker spike. So the QRS looks like a combination of both those beats because ventricular activation came from the fusion of two different sources. Understanding how to interpret these pacemaker strips relies on knowing how the pacemaker works. Essentially, pacemakers are built like a clock. And think of this clock as set for a certain period of time. For example, if the pacemaker is programmed for 60 beats per minute, that means every beat takes 1 second, and therefore the clock runs for exactly 1 second, or 1,000 milliseconds. With every paced beat, that clock starts, and if the clock runs out, then the pacemaker sends out another pacemaker spike, resulting in the next heartbeat. That starts the clock again, and when the clock runs out, the pacemaker paces the heart again. If you measure the time between two spikes, you can tell what rate the pacemaker is set for, because that's how long the clock is running for. In this case, the fourth beat is also paced, but watch what happens when the patient's own heartbeat occurs. Here, the clock would run until here, but this intrinsic beat occurred before the clock ran out. When an intrinsic beat is seen by the pacemaker circuits, the output of the pacemaker is inhibited, so there's no pacemaker spike, and this sensed event starts the clock again. In this case, there are 3 additional beats that occur before the next pacing spike. It's very useful to use a pair of calipers in analyzing the paced heart to show you at what moment the clock started. Since we know the clock is running at this interval, if we place the calipers on this spike and measure back, we can see that the pacemaker actually put a spike out at this moment. The spike is hard to see there, but this is a problem with ECG machines trying to pick up tiny pacemaker complex. At this point, single-chamber pacemaker system problem occurs. If an intrinsic beat is followed by a intermittent fracture, or it can be due to an elevated threshold, which is the amount of the strip. If an intrinsic beat interrupts the next cycle of the clock, then the pacemaker output should be inhibited and the clock should start again. So measuring back from a spike will show you when the clock started. In this top strip, we can see pacing spikes occurring here and here, but they're occurring soon after an intrinsic QRS complex. We don't know for sure what rate this pacemaker is set at, but we know it would have to be less than the intrinsic R to R, otherwise it would be pacing all of the time. And so if we measure back from this paced beat, chances are it sensed this QRS, but the pacemaker is one paced in this systems. I showed indication broken conductor interval permanent pacemaker. We discussed single and dual chamber pacemaker systems. I showed you how leads are constructed, and we talked about the difference polar sensing, sensing by an interpected, and oversensing, which results in longer than expected intervals before a paced beat. Sensing expected than a beat. We just to be, and this may be here. F here is intermittent, is sensed occurring paced beat. We can see pacing spikes. It interrupts the next cycle of the clock. Then the pacemaker output should be inhibited and the clock should start again. So measuring back from a spike will show you when the clock started. In this top strip, we can see pacing spikes occurring here and here, but they're occurring soon after an intrinsic QRS complex. We don't know for sure what rate this pacemaker is set at, but we know it would have to be less than the intrinsic R to R, otherwise it would be pacing all of the time. And so if we measure back from this paced beat, chances are it sensed this QRS complex, but did not see this one. And so the interval from an intrinsic beat to the pacemaker spike is shorter than it should be. And this gives you a clue that there is undersensing. Here's a very obvious example of undersensing, with pacemaker spikes occurring right after an intrinsic QRS complex. And in fact, this spike lands on top of the T wave. If we again use a pair of calipers and set it for this interval between spikes, we can see that this interval is the same. If If we measure back from the spike, it appears that the pacemaker probably sensed this beat, but did not sense this one. However, there are no other spikes in here, and so it was inhibited by some of these beats. So what we have here is intermittent failure to sense, otherwise known as undersensing. The last example here is known as oversensing. Other pacemaker problems can cause this kind of loss of pacemaker output. We can see pacemaker spikes going along here at a rate of about 90 beats per minute, but then the spikes disappear and we have an escape beat here with underlying complete heart block. And then there's one paced beat and then a loss of pacing spikes until they resume here. But the pacing rate here is much slower than it is here. And it's likely that noise from a broken conductor is inhibiting the output of the pacemaker. In this case, the interval between beats is much longer than we expect it to be, and this may be a sign of oversensing that results in inhibition of the pacemaker output. In summary, we talked about the different indications for a permanent pacemaker. We discussed single and dual chamber pacemaker systems. I showed you how leads are constructed, and we talked about the difference between unipolar and bipolar pacemaker systems. I introduced the concept of pacemaker timing cycles and the functioning of a single-chamber ventricular pacemaker system. And finally, I showed you examples of failure to capture, as well as undersensing, diagnosed by an interval that's shorter than expected, and oversensing, which results in longer than expected intervals before a paced beat. Is a very obvious example of undersensing, with pacemaker spikes occurring right after an intrinsic QRS complex, and in fact this spike lands on top of the T wave. If we again use a pair of calipers and set it for this interval between spikes, we can see that this interval is the same. If we measure back from the spike, it appears that the pacemaker probably sensed this beat, but did not sense this one. However, there are no other spikes in here, and so it was inhibited by some of these beats. So what we have here is intermittent failure to sense, otherwise known as undersensing. In this video, we're going to talk about dual-chamber pacemakers. I'll complete the discussion on pacemaker nomenclature. I'll explain dual-chamber pacemaker timing cycles, as this is critically important to troubleshoot pacemaker ECGs. We'll describe the 4 different behaviors that a dual-chamber pacemaker is capable of. I'll discuss some of the program parameters that can be changed in a permanent pacemaker, and we'll examine how pacemakers can change their behavior based on the patient's need and 2 leads. One to the patient's needs. Patient's need and 2 leads. One to the right atrium consists of the pulse generator and dual-chamber pacemakers consist of the pulse generator and 2 leads. One to the right atrium and one to the right ventricle. The leads can be positioned almost anywhere within these 2 chambers. Each lead delivers a tiny electrical signal that results in depolarization. The pacemaker system is also capable of detecting the underlying rhythm, and so the pacemaker needs to be able to both sense as well as capture either chamber. with the goal being to maintain the proper timing between the atria and the ventricles, known as AV synchrony. In order to accomplish all this, the pacemaker circuitry has to be very complex, much more than a single-chamber pacemaker. But before we get to the complexity of the pacemaker circuitry, I wanted to review some of the naming conventions that have been developed over the years. When people talk about pacemakers, it's almost like an alphabet soup: VVIR and DDD and MVP. And so the next discussion is going to make some sense out of this. This code contains 3 letters. The first letter is the chambers that are paced, the second letter are the chambers that are sensed, and the third letter refers to how the pacemaker responds to a sensed event. Let's talk about the different ways a pacemaker can respond to letters. The first letter is the chambers that are paced, the second letter are the chambers that are sensed, and the third letter refers to how the pacemaker responds to a sensed event. Let's talk about the different ways a pacemaker can respond when it senses an intrinsic signal. If a sensed event suppresses the output of the pacemaker, it's known as inhibited. Whereas if a sensed event results in a paced event, sensed event. Let's talk about pacemakers. It's almost like an alphabet soup: VVIR and DDD and MVP. And so the next discussion is going to make some sense out of this. This code contains 3 letters. The first letter is the chambers that are paced, the second letter are the chambers that are sensed, and the third letter refers to how the pacemaker responds to a sensed event. Let's talk about the different ways a pacemaker can respond when it senses an intrinsic signal. If a sensed event suppresses the output of the pacemaker, it's known as inhibited. Whereas if a sensed event results in a paced event, we call that a triggered response, meaning that this is the output of the pace. Third letter refers to how the pacemaker responds to a sensed event. Let's talk about the different ways a pacemaker can respond when it senses an intrinsic signal. If a sensed event suppresses the output of the pacemaker, it's known as inhibited. Whereas if a sensed event results in a paced event, we call that a triggered response, meaning that the pacemaker puts out an electrical signal in response to some intrinsic cardiac event. If we examine this letter code a little bit more carefully, remember that the first letter is the chamber that's paced. And the letters used in this position include A for atrium, V for ventricle, electrical signal. In response results in a paced event, we call that a triggered response, meaning that the pacemaker puts out an electrical signal in response to some intrinsic cardiac event. If we examine this letter code a little bit more carefully, remember that the first letter is the chamber that's paced. And the letters used in this position include A for atrium, V for ventricle, D for dual, meaning that the pacemaker is capable of stimulating either the ventricle or the atrium, and S standing for single, which is a generic label for a pacemaker that can be used either in the atrium or the ventricle. The letter O is reserved for pacemaker modes that do not pace at all. The same letters can be used in the second position, which refers to the chambers that are sensed. A stands for atrium, V for ventricle, D for dual, and S for single. If the pacemaker is not able to sense either chamber, then an O is used. The third letter is the response to sensed events. I stands for inhibited, meaning that an intrinsic cardiac event will prevent the pacemaker from sending out a spike. A triggered mode means that an intrinsic cardiac event will trigger the output of the pacemaker. And the letter D in the third position means that the pacemaker is capable of working in both inhibited and triggered modes depending upon the patient's needs. Generally, O is used in the third letter when pacemaker function is disabled. There is a fourth letter that is often tacked on to the end, and that is the letter R. The letter R refers to pacemakers that are able to adapt the heart rate depending upon the patient's activity. Rate adaptive or rate responsive behavior increases the heart rate as the patient engages in physical activities such as walking or exercise. So a single chamber pacemaker in the ventricle would be considered a VVI, mainly because these pacemakers are inhibited by intrinsic ventricular events. This is also known as a demand pacemaker because it only paces when the patient needs it. If the pacemaker responds to the patient's activity, we designate it as a VVIR. This feature is actually programmable on or off, and so the R refers mainly to how the pacemaker behaves, not necessarily to its capability. And that's why sometimes confusion arises, because a pacemaker can change the way it behaves, and that will change the letter configuration as well. This letter configuration is often referred to as the pacing mode. Dual-chamber pacemakers are generally DDDR, meaning they pace in both chambers, they can sense in both chambers, the response can be inhibited or triggered depending upon the patient's needs, and the R can be programmed on or off depending upon whether the patient needs rate-responsive pacing. Next, we'll go over how DDD pacemakers can change the way they behave. Remember that I used the analogy of a clock when talking about single-chamber pacemakers. With dual-chamber pacemakers, the circuitry acts like two clocks. The first clock determines how much time there should be between the atrial event and the ventricular event, and we refer to this as the AV delay. The second clock has to do more with the rate of the pacemaker, because that's the other major setting that we can change when programming a pacemaker. We'll take a simple example. Let's say we have a DDD pacemaker. We can program the rate, otherwise known as the lower rate limit, for 60 beats per minute, and the AV delay for 200 milliseconds. Ideally, that'll result in an atrial spike and a paced P wave, followed by a ventricular spike 200 milliseconds later, followed by a paced QRS complex. And then with the next atrial spike, we'll create a heart rate of 60 beats per minute, or exactly 1 second in between beats. In order for the circuitry to accomplish this, we have to know how much time there is from the ventricular spike until the next atrial spike. This is referred to as the atrial escape interval and is calculated by the circuitry in order to create this lower rate limit. In other words, if the AV delay is programmed for 200 milliseconds, the circuitry is looking for 800 milliseconds of an atrial escape interval in order to create a heart rate of 60 beats per minute. That means we don't talk about a rate timer, we talk about the atrial escape interval timer. And with these programmed, so atrium escape AV pace. Let's now take an example of a different patient with the same pacemaker, programmed with the same parameters, 60 beats per minute as a lower rate limit and 200 milliseconds as an AV delay. However, let's assume that this patient received the pacemaker because of sinus node dysfunction, but their AV conduction is quite good. In this case, what happens is an atrial pacing spike results in a P wave, but that P wave manages to get down the AV node fairly quickly, resulting in a normal QRS complex. In this diagram, the atrial pacing spike results in a P wave that senses with the successful circle. In this event, this is observed. Atrial B block, so we'll give it the AV delay timer once again, and this timing cycle repeats itself over and over. So in the diagram, the sinus nodal signal is sensed by the atrial lead, and at the end of the AV delay timer, ventricular pacing occurs from the right ventricular lead. This is referred to as atrial synchronous ventricular pacing. We also refer to this as tracking of the underlying sinus rhythm, and it's a mode that uses triggered behavior of AV being interrupted, evidence for intrinsic ventricles, AV rhythm, and like different appearance patient's needs. A third kind of behavior can be seen in patients with normal sinus node function, but they have AV block. In that case, what happens is an intrinsic P wave is occurring because of the presence of it. A AV P wave will come along before to the it's almost certain 60. It's on paced effect ventricle challenge wave well, and the delays may have adverse effect in the event of AAI behavior allows you to make
So I've got my essay written, and I've been working on it for about a week. So now I'm going to show you how I use Grammarly to...
Please take a moment. The producer in this menu provides the topics.
This module deals with sinus node function. This first video will cover sinus node physiology. We'll discuss the anatomy of the sinus node. I'll show you the action potential of a pacemaker cell and how it differs from a normal myocardial cell. We will discuss the function of the sinus node. We'll review what a normal sinus rhythm looks like on an electrocardiogram. And finally, I'll show you some basic examples of sinus arrhythmia. Let's first talk about the anatomy of the sinus node. This is an external view of the heart, somewhat rotated so that you can see the right side of the heart mostly, since the conduction system is mainly on the right. The right atrium and the right atrial appendage are shown here. The right AV groove is where the coronary arteries run, and this is painted in yellow since it's often filled with fat. And the right ventricle is located on the front surface of the heart. We can actually slip a catheter up the aorta and take a picture of the right coronary artery during a cardiac catheterization. And I can now superimpose that image over the heart. Here is the catheter coming down, engaging the ostium of the right coronary artery. Here is the main body of the right coronary artery that runs around the right AV groove to the back of the heart, or the crux of the heart, and then becomes the posterior descending artery. It runs towards the apex. Right here is where you'll find the sinus nodal artery. It runs up the atrial wall, and it branches up near the sinus node. The sinus node is actually located at the junction of the right atrial appendage and the superior vena cava. So if here's the superior vena cava coming down, and here's the back wall of the right atrium, the right atrial appendage sticks out over the front part of the heart, and the sinus node can be found right in this region. The sinus nodal artery runs right through it, and if you magnify this region, the sinus nodal artery branches, and around that area is where the sinus nodal tissue resides. Now, these are specialized cells, pacemaker cells, that generate the signals that run the heartbeat. Now, there are extensions of the sinus nodal tissue out into the atrial myocardium, and these extensions become important in the conduction of the signal from the sinus node out to the neighboring little talk of particles known as myocardium, and cells function differently than the normal heart muscle cells. Every cell in the heart is capable of generating a little tiny electrical signal as charged particles known as ions move in and out of the cell. This complex series of events is known as the cardiac characteristic between these three differently. These happen fluctuations is the case about autonomic nervous system signals. Generally, by looking is a little bit shorter. There can be the rate here is about 64 beats per minute with a normal PR interval and a normal QT. So this would be considered a normal sinus rhythm. Notice the P waves appear to be consistent. They all look alike because the signal is emerging from the same point in the heart. If you place a pair of calipers on the R to R interval and move it along, most of the R to R intervals are consistent. But this one, for example, is a little bit longer, whereas this one is a little bit shorter. There can be a cyclical change in the heart rate that's considered normal and is referred to as sinus arrhythmia. It's due to changes in the rate of firing of the sinus node due to slight alterations in the autonomic tone, in particular the parasympathetic tone carried by the vagus nerve. Here is another example of a normal sinus rhythm with upright P waves in 1 and 2, as well as AVF. In this tracing, the fluctuation of heart rate is much more obvious. If we scan across the rhythm strip, we can see that some of the R to R intervals are quite short, here at a rate of about 80 beats per minute, and then a couple of beats later, it slows down to about 65 beats per minute. You can also detect slight changes in the P wave size and shape. Although all the P waves are upright, you can see that some of the P waves are flattened compared with others. These minor changes in P wave morphology are normal in cases of sinus arrhythmia. And it's most likely due to the fact that during sinus arrhythmia, faster beats exit the sinus node from higher, more medial extensions. And with slowing of the sinus node, the impulse tends to emerge from a lower, more lateral extension. This results in very slight alterations in the P wave morphology. In summary, the sinus node is a specialized structure that's responsible for controlling the heart rate. The unique pacemaker cells within the sinus node generate small electrical signals that produce the normal sinus P waves. The sinus node depolarizes because of calcium currents rather than sodium, like most other cells in the heart. The sinus node is exquisitely sensitive to changes in the autonomic nervous system, resulting in variations in the heart rate. The sinus nodal signal is conducted to the atrial myocardium through these extensions of the sinus node. A normal sinus rhythm is often accompanied by sinus arrhythmia due to cyclical changes in vagal tone. In this video, we're going to start talking about different presentations of sinus node dysfunction. We'll discuss the effect of activity on heart rates and learn how the autonomic nervous system influences the sinus node. We'll review the appearance of sinus arrhythmia on an ECG, and I'll show you examples of sinus bradycardia. We'll discuss the clinical diagnosis of chronotropic incompetence. And finally, you'll learn to recognize sinus pauses and sinus arrest. As we discussed in an earlier video, sinus nodal cells depolarize on a regular basis, and that determines the heart rate. Depolarization actually, but well-conditioned athletes can stock, at which end brain that can blood, and they make a predominant and spreading down into the patient normal. This is an example. After just 5 beats, the rate suddenly slows down dramatically to less than 50 beats per minute. These sudden rapid decreases in heart rate are often due to parasympathetic or vagal influences on the sinus node. This ECG came from a 25-year-old healthy young woman. It's an example of marked sinus arrhythmia, but in young patients, it's generally considered to be normal. This is an example of sinus bradycardia. There are normal P waves that are up in 1 in AVF, but the rate is obviously very slow. We'll find a QRS that lands on a heavy line, and we can count off the heart rate: 300, 150, 100, 75, 60, 50. The heart rate is fairly stable, and we would consider this simply sinus bradycardia. In a healthy young person or someone who's well conditioned, this degree of sinus bradycardia is generally considered normal. However, if the heart rate is insufficient to meet the body's needs because of abnormal function of the sinus node, that syndrome is known as sinus node dysfunction, otherwise known as sick sinus syndrome. Sick sinus syndrome often presents with complaints of fatigue, exercise intolerance, shortness, which can come the heart depend a cause of death and have, but it did not arrest by as pauses. I'll show you some important ECG, but during this part of the action is wants to find sinus node winds up suppressing thectrium, which is stimuli, and sinus node cardiac the arrhythmia, and then these I want to densely. So if you see clear P waves, they must be there, and that would act compete kind of pacemaker fact known as make.